Hi everyone, and welcome to our module on demyelinating diseases. So there are 7 demyelinating conditions you should know about as a medical student, and far and away the most common and the most tested is multiple sclerosis. After that there's Guillain-Barré syndrome, which you sometimes see clinically, and then the remainder of these conditions are very rare, and we'll just talk about what you need to know for the boards. So let's talk about multiple sclerosis first. This is an autoimmune disease where nerve cells in the central nervous system lose their myelin sheath. It affects the brain and the spinal cord, and the classic demographic is a young woman, usually in her 20s or 30s. It most commonly follows a relapsing remitting course, and what do I mean by that? That means that patients will get a neurologic symptom like weakness of an arm or tingling in the face, and then it will go away. And then a few weeks later they'll get a second symptom in a different place. That's called relapsing and remitting. There are a diverse set of neurosymptoms that can come and go over time, and the classic teaching is that multiple sclerosis can cause any neurological problem. And one thing you should know is that fatigue is a very big problem for people with this condition. Women, when they're first diagnosed, are often very, very tired. And a classic thing is for a person to feel fatigued after a hot shower. There's less nerve transmission in hot environments, so if you've got multiple sclerosis, you can get worse after a hot shower. And heads up for that on a boards question. What's happening at a cellular level in multiple sclerosis is highly complex, and you should know that there's a lot of conflicting evidence in the scientific literature about how much different immune system cells and antibodies play a role. However, I've summarized on this slide some of the key points that are worth knowing, especially for step 1 of the boards. You should definitely know that lymphocytes and especially T cells have been shown to react to myelin antigens as part of the pathophysiology of multiple sclerosis. And one of the things that they appear to react to is something called myelin basic protein, which is found in the central nervous system. A very important cytokine in multiple sclerosis is interferon gamma, which, as you may know, is often released by T cells, so this makes sense. And interferon gamma can recruit macrophages, and macrophages are also very important in the pathophysiology of multiple sclerosis. And then finally, you should know that multiple sclerosis is often classified as a type 4 hypersensitivity reaction. So type 4 hypersensitivity reactions are those that involve T cells and macrophages and don't involve antibodies. Now, in reality, this is probably an oversimplification. Antibodies do have some role in multiple sclerosis, and B cells also have some role, but this is the way to remember it for step 1. So let's talk about the symptoms of multiple sclerosis. As I said before, any neurosymptom is possible, and that's why multiple sclerosis is a very challenging disorder to diagnose. But there are a few classic presentations that you should know about. The first one is optic neuritis. This is demyelination and inflammation of the optic nerve, and patients who get optic neuritis have pain with eye movement and loss of vision in one eye, and that's a classic presentation for multiple sclerosis. The second one is a medial longitudinal fasciculus syndrome, which is also called an internuclear ophthalmoplegia. I talk about this in more detail in the module on neuro-eye disorders, but patients who develop this will not be able to move their eye medially on lateral gaze, and what they will complain about is double vision or diplopia. And then finally, many patients with multiple sclerosis initially present with bladder dysfunction. So they can have spasms of their bladder, which cause them to have incontinence. They can also fail to sense their bladder and then have overflow incontinence. But the take-home message is that bladder dysfunction is often involved in patients who have MS. So MRI is the gold standard for diagnosis of multiple sclerosis, and we'll see some pictures of that in a minute, but there are some other diagnostic tests that you should know about. So if you look at the pathology of the brain of a patient with multiple sclerosis, the classic finding are paraventricular plaques. So these are plaques near the ventricles of the brain, and they show loss of oligodendrocytes, and that should make sense because the oligodendrocytes are the cells that create myelin in the brain, and they will show evidence of reactive gliosis. If you test the CSF of a patient with multiple sclerosis by doing a spinal tap, you will see high proteins and something called oligoclonal bands. Oligoclonal bands are proteins of a certain size, and they are typically seen in multiple sclerosis. They don't clinch the diagnosis, but they are highly suggestive. So these are some MRIs from some patients with multiple sclerosis. Over here on the left is a patient who has white plaques protruding out from the ventricles, and when they protrude in straight lines like that, they're called Dawson's fingers. Over here on the right, there's a patient with some white inflammation around one of the ventricles, and that's typical for multiple sclerosis. This is another image of a person's brain, and note that there are white plaques in 2 different spots, and so in multiple sclerosis you will often see more than one spot. In fact, if you image the brain serially over time, you'll see some of these go away and others come back, and that's the relapsing remitting nature of multiple sclerosis. You aren't likely to be asked about multiple sclerosis treatment on your boards because it's extremely complex. It's something done by highly trained neurologists, but just a little bit of this here so you're aware. So rare patients with very mild symptoms and just 1 or 2 lesions and no flares sometimes can be watched without therapy. The mainstay of treatment for patients with mild symptoms is something called interferon. It's injectable and it seems to limit the progression of the disease. And then there are some newer agents which are powerful anti-inflammatories. We don't know exactly how they work, and both of these are sometimes being used. Some of them are oral agents that multiple sclerosis patients can take to try to limit disease progression. Next, let's talk about the Guillain-Barré syndrome. This is an acute inflammatory demyelinating disease, and the key word is acute. This comes on rapidly over days to weeks. In Guillain-Barré syndrome, the Schwann cells get destroyed by the immune system, and recall that the Schwann cells myelinate the peripheral nerves. Patients with Guillain-Barré have an ascending muscle weakness, and remember the word ascending because it usually starts in the legs and then spreads to other areas. This can be serious and life-threatening. About a third of patients can have respiratory failure where they end up on the ventilator from Guillain-Barré. More than half of patients end up with facial muscle weakness, so they have drooling and dysphagia. There are some sensory deficits, but they're usually very mild, limited to things like paresthesias, which are just numbness and tingling in the extremities. And the symptoms usually resolve over weeks to months, but it can be a brutal few weeks to months. If you ever see a patient with Guillain-Barré, they can be extremely debilitated until the condition resolves. So this is a picture of a peripheral nerve, and we talk about this in another module on basics of the nervous system, but you should know that the endoneurium right here is the classic area that gets affected by Guillain-Barré. So when you hold a nerve in your hand in the anatomy lab or in the OR, what you're holding is a nerve trunk, and that's this whole structure here. But inside of it, it has all these fascicles surrounded by a structure called the perineurium. Inside the fascicles, there is endoneurium surrounding each individual axon, and that's what gets affected in Guillain-Barré syndrome. In addition to the motor weakness that starts at the feet and works its way up, patients with Guillain-Barré get autonomic dysfunction. So they get tachycardic, they won't be able to urinate, they can have hyper or hypotension. Some of them get arrhythmias, some of them get ileus, and some of them can't sweat. And severe autonomic dysfunction can cause sudden cardiac death, and that's the way some people die from this condition. Guillain-Barré is often triggered by infection, and the two classic agents are Campylobacter and cytomegalovirus. So in Campylobacter, a patient will have an episode of bloody diarrhea, and that will resolve, and then a few days or weeks later, they'll develop the ascending muscle weakness of Guillain-Barré. Cytomegalovirus is usually asymptomatic in healthy people, and the only way it's been associated with Guillain-Barré is by finding the antibodies. But some people who are immunocompromised get symptomatic cytomegalovirus infections. So this might be a patient who's immunosuppressed after a transplant on immunosuppressant drugs, or maybe someone with HIV, and they'll have sort of a mild febrile illness from the cytomegalovirus, and in a few days or weeks later, they'll develop the muscle weakness related to Guillain-Barré syndrome. If you test the CSF with a spinal tap in patients with Guillain-Barré syndrome, it will show an elevated protein level. It's a non-specific finding, but that's what you'll see. All the other counts in the cerebrospinal fluid should be normal. So the way you treat Guillain-Barré syndrome is first by supporting the breathing of the patient. They often have to go on the breathing machine because their respiratory muscles get weak. And then we sometimes do something called plasmapheresis. This is a plasmapheresis machine over here. And what it does is removes plasma from the cells in the bloodstream and then feeds the cells back to the patient with donated plasma. It basically removes antibodies from the circulation, and it has some evidence that it helps in Guillain-Barré. And sometimes we administer something called IVIG, or intravenous immune globulins. This is a bunch of pooled antibodies from over 1,000 patients, and for reasons we don't understand, it helps in some conditions, and Guillain-Barré is one of those conditions. Next demyelinating condition we're going to discuss is called progressive multifocal leukoencephalopathy, or PML, and this is a disease that occurs when you have reactivation of the JC virus. So the JC virus is ubiquitous. Many of us have been exposed, but if your immune system works, it doesn't cause a problem. However, if you become immunocompromised, usually from end-stage HIV, then the JC virus can reactivate and cause PML. Patients with PML get multiple white matter lesions on brain imaging. That's where it gets its name of multifocal. And the disease process destroys the oligodendrocytes. And to get this with HIV, you have to have a CD4 count usually less than 200, so fairly low. And HIV patients with PML get a slow onset encephalopathy where they have altered mental status. And then depending on which areas of the brain are demyelinated, they can get focal neurodeficits like motor loss and ataxias. You can diagnose it by finding the JC virus DNA in the cerebrospinal fluid or by a brain biopsy, and this generally carries a very poor prognosis. Most patients who develop PML do not survive more than another year or two. The only real treatment is to try and reconstitute the immune system. Next, let's talk about post-infectious encephalomyelitis. This is a demyelinating disease that occurs acutely and rapidly, and it can follow infection or vaccinations. It often gives a rapid clinical deterioration of weakness that leads to hospitalization. So this comes on about a month or so after an infection or vaccination. It's been reported after varicella or measles infections, and it's been reported after rabies and smallpox vaccination. And the most important thing to know for your boards here is the histopathology. So it has what's called perivenous infiltration. So there are sleeves of inflammatory cells around the veins in the central nervous system, and this is different from multiple sclerosis where there are plaques. In these perivenous sleeves you see lymphocytes and neutrophils and other cells, and there's inflammation and loss of myelin. And this is an example of what you can see on brain imaging. There are these hypodense, which means dark circles in the brain, and that's classic for post-infectious encephalomyelitis. Next, we'll talk about Charcot-Marie Tooth, which is a very rare hereditary condition. It's also called hereditary motor and sensory neuropathy. It's a progressive problem of the peripheral nerves, and mostly it affects the lower extremities. The peroneal nerve is one of the most commonly affected. So this will happen to older kids or people in adolescence, and what happens is they get defective production of proteins and myelin, and basically their legs become wasted because of loss of innervation down in the lower extremities. They have this characteristic stork-like contour and foot drop, and they can have foot deformities, and that's the way you're going to recognize this in board questions. It's going to be a patient with weakness who has severe deformities of the lower extremities and feet. The upper extremities are sometimes affected, but not as much as the lower, and these patients will have falls and clumsiness. So when you see falls and clumsiness in a board question, you might start thinking of ataxia and cerebellar things, but when you see that the feet and the legs are very abnormal, you should think of this problem. And here's an example of some of the deformities they get. They get something in their feet called pes cavus deformities, where the feet have this very abnormal, crunched up sort of shape and very skinny legs. They can get something called claw hands, where their hands are abnormal. And this is all from loss of peripheral myelination. Metachromatic leukodystrophy is one of the storage diseases. It's a lysosomal storage disease. It's rare. It's autosomal recessive. So remember, when something's autosomal recessive, both parents have to have the mutation. It causes progressive demyelination everywhere in the body, central and peripheral nervous system. And it's caused by an aryl sulfatase A deficiency, and you build up these compounds called sulfatides which impair the production of myelin. There's three forms of this disease. There's a late infantile form that affects babies, and then there's a juvenile form and an adult form. And so infants and children who have this are going to present with failure to reach their milestones. So they're not going to start crawling when they're supposed to or walking when they're supposed to. And that's why when you do a pediatrics rotation, you spend a lot of time making sure the baby is at the appropriate activity level for its age range, because if it's not, it could have something like this. Children and adults are going to present with ataxia and dementia from all the central nervous system demyelination. Krabbe's disease is also a lysosomal storage disease. It's also autosomal recessive. In this case, it's a deficiency of galactocerebrosidase, and you build up galactocerebrosides, and this destroys the myelin sheath. People with this condition almost always present as babies, and they have progressive motor and sensory problems. So the baby will be irritable, it'll have developmental delay, the limbs will be spastic or hypotonic, there'll be absent reflexes, and there'll be a tiny head. And this is part of the reason you're always checking the head size of babies and comparing it to a growth chart. If it's small, it could be something like this, and if it's large, they could have some kind of hydrocephalus. And that concludes our module on demyelinating disease.